and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. Interstitial lung disease remains a common and potentially fatal complication of rheumatoid arthritis, with clinically relevant ILD identified in approximately 5 to 15% of people living with RA. Right now, ACR guidelines do recommend screening for ILD in RA patients. But what if there was a way to identify which patients need screening earlier? The manuscript we will discuss today is performance of an idiopathic pulmonary fibrosis-derived multi-biomarker panel for rheumatoid arthritis-associated interstitial lung disease. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures is available in today's show notes. I'm excited to be joined today by the first author of this manuscript, Dr. Brent Luedders. Dr. Luedders is a rheumatologist and an assistant professor at the University of Nebraska College of Medicine, Division of Rheumatology. He completed his medical school training and residency in internal medicine at the University of Nebraska, and his research and medical interests include spondyloarthritis, musculoskeletal ultrasound, the study of peripheral blood markers for rheumatoid arthritis-associated interstitial lung disease, and, of course, medical education. Welcome to the show, Brent.
Happy to be here. Thanks for having me.
To start, I'd love to step back a little bit and learn about the broader landscape of biomarkers in ILD. Over the years, numerous studies have explored different candidate biomarkers for both idiopathic ILD and RA-associated ILD. Could you walk us through some of those foundational studies and how they shaped the groundwork for your study?
Yeah, so over the years, there's been a growing body of evidence looking at biomarkers associated with RA-ILD. One of my research mentors and a co-senior author on this manuscript, Brian England, published a systematic review in 2023 in ACR Open Rheumatology, which is a good reference for biomarker studies in RA-ILD. By that time, over 100 biomarkers had been reported and at least one study to have associations with RA-ILD. Some of the more commonly studied categories include autoantibodies, cytokines and chemokines, genetic markers, pulmonary damage biomarkers, and growth factors. While many biomarkers have been studied on RA-ILD, there are limitations in many of these studies related to sample size, unadjusted analyses, as well as lack of external validation. There are a handful of biomarkers that may hold greater promise as RA-ILD biomarkers. The MUC5B promoter variant is a well-established genetic risk factor for idiopathic pulmonary fibrosis, or IPF. In a 2018 publication in the New England Journal of Medicine, the MUC5B promoter variant was also shown to be associated with about 3 times the odds of RA-ILD, but not associated with RA alone. Similar findings have also been replicated in other cohorts. We recently published findings of fairly strong associations of matrix metalloproteinases, or MMPs, most specifically MMP7 with RA-ILD. There have also been a number of controlled studies showing associations of KL6, which is a pulmonary damage biomarker with RA-ILD. Setting the stage for our recent manuscript, our other co-senior author, Dana Asherman from the University of Pittsburgh, published a study in 2020 in Arthritis and Rheumatology. This study evaluated a multiplex biomarker assay in RA patients with and without ILD, IPF patients, as well as healthy controls. This assay included a number of cytokines, chemokines, MMPs, and growth factors, a number of which were associated with RA-ILD and IPF individually. This also included a subset of biomarkers having overlapping associations with both IPF and RA-ILD, and this was a pretty relevant study to our current project.
Yeah, that's great. So you mentioned that many of the previous studies have some limitations in design. Let's talk about your study design. It was kind of complicated. You drew on a couple of different cohorts, including patients from the VARA registry, or Veterans Affairs Rheumatoid Arthritis Registry, and then also some participants from non-VA cohorts. What was the rationale for bringing these distinct groups together? And for our listeners, can you break down how you structured the cross-sectional component and then how you approach validation?
Yeah, so it can get a bit confusing as we used a few different cohorts in this study, but we basically studied the multi-biomarker score in 2 different development cohorts using a cross-sectional design, and then validated the score in a much larger independent cohort with both cross-sectional and longitudinal designs. One of the development cohorts consisted of 71 RA patients from 2 academic medical centers, and the other consisted of 103 patients from several VA sites. In these cohorts, we compared the multi-biomarker score across the categories of RA alone, RA with subclinical ILD, and RA-ILD, which was further subdivided into non-UIP and UIP. To validate the score, we looked at the Veterans Affairs Rheumatoid Arthritis Registry, or VARA registry. This is a multi-center, prospective, longitudinal registry of RA patients seen at several VA sites across the country that was established in 2003. Our study included over 2,500 RA patients who were followed for a mean of 8.4 years. Within the VARA registry cohort, we completed cross-sectional analyses assessing the association of the multi-biomarker score with prevalent RA-ILD at registry enrollment. We also completed longitudinal analyses among those without RA-ILD at study enrollment to assess whether the multi-biomarker score might be predictive of which patients would develop RA-ILD in the future.
Yeah, it's great. And I'm assuming a good part of the reason you used the VARA registry for this was just they had such robust longitudinal follow-up.
Yeah, so the well-established registry, longitudinal follow-up over many years was a convenient source to really take these smaller cohorts and take a bigger look at this panel.
Yeah, it's really helpful. So tell us, which biomarkers did you study? What was in the panel you were designing, and why? Why did you choose those biomarkers?
Yeah, so there were a total of 8 biomarkers included in our multi-biomarker panel, and these were really selected based on that previous study from Dr. Asherman that showed associations of these biomarkers with IPF. The biomarkers that we included in this panel included eotaxin, IL-8, FLT3 ligand, macrophage-derived chemokine, monocyte chemoattractant protein 1, and 3 matrix metalloproteinases, so MMP2, 7, and 9.
How did you assess the patients for that ILD diagnosis?
So this differed slightly between the different cohorts. For the smaller development cohorts, patients were comprehensively assessed for RA-ILD, including symptom assessment, pulmonary function testing, and chest CT scans with a blinded radiology review. In the VARA cohort, patients are followed per standard of care, and therefore not all patients have had a comprehensive pulmonary evaluation. So to create an ILD cohort within the VARA registry, we performed a systematic record review where patients were screened for the presence of ILD by diagnostic codes. These records were then formally reviewed and classified as RA-ILD if they were diagnosed with ILD by the treating provider and also had findings supportive of ILD either on chest CT for the vast majority of patients or a handful of patients that had lung biopsy findings.
Before we dive into the results, I think it'd be helpful to know, were there any important differences in baseline characteristics of all of these different cohorts that we should be aware of?
I think it's worth pointing out some of the demographic differences between the cohorts. So in the non-VA development cohort, about 2/3 of the patients were females, whereas the VA development cohort, as well as the VARA validation cohort, were a more typical veteran population consisting primarily of males who are relatively older and with higher rates of current and past smokers. Across the cohorts, there was a fairly long-standing RA disease duration, including an average of about 11 years in the VARA cohort.
Okay, so I think we're ready to jump into some of the results. I like people to walk us through their graphics a little bit. You have some very cool ones. Let's start with figure 1, which shows the biomarker scores in the VA and non-VA cohorts among the patients with RA and no ILD, subclinical ILD, and UIP and non-UIP ILD patterns. That's an alphabet soup. What did the analysis show?
Yeah, and I think one important thing when looking at the paper to note here is that the way that we calculated the multi-biomarker score was based on cohort-specific standardized values. So this was relative to the mean and the standard deviation of the individual analytes within each cohort. So the score itself cannot be readily compared between the different cohorts making up the study. However, for this figure within both of the development cohorts, we saw that the multi-biomarker score was not significantly different between RA patients without ILD and RA patients with subclinical ILD. In comparison, we saw that those with both UIP ILD and non-UIP ILD had higher mean multi-biomarker scores than patients with RA alone. There was also a trend for higher multi-biomarker scores in UIP versus non-UIP ILD, but this was statistically significant in only the non-VA cohort.
Yeah, interesting. So when you looked at the validation cohort, looking at the prevalent and incident RA-ILD, what did you find there?
So there were a total of 106 prevalent RA-ILD cases for our cross-sectional analysis, as well as 153 incident cases of RA-ILD in longitudinal follow-up. These were analyzed with over 2,200 controls with RA alone. In the validation cohorts, we were able to perform regression analyses to control for other RA-ILD risk factors such as age, sex, smoking history, as well as baseline RA disease activity. We completed separate analyses looking at the multi-biomarker score as a continuous measure, as well as categorically divided into quartiles. We found that the multi-biomarker score was significantly associated with the presence of prevalent RA-ILD at baseline. Among RA patients without ILD, the score was also associated with the future development of incident RA-ILD in longitudinal analyses. Among those with the highest quartile of multi-biomarker scores, there was approximately twice the odds of prevalent RA-ILD and nearly 2.5 times the risk of developing incident ILD in follow-up.
Yeah, amazing. So a bit of a signal. You also then examined the receiver operating characteristic or ROC curves for the clinical predictors and the multi-biomarker score. That's figure 2 of the manuscript. What does that show?
So the ROC curves are one way of assessing the diagnostic accuracy of a test. In our study, we found that the area under the ROC curve was not significantly different with the addition of the multi-biomarker scores compared to clinical risk factors alone. This suggests that the score does not add meaningfully to the ability to discriminate RA-ILD from RA without ILD, at least above those established risk factors.
Yeah, so a signal, but not quite there yet. You then, in figure 3, investigate the cumulative hazard of incident RA-ILD using the multi-biomarker score quartiles. That was quite interesting. Tell us what you found there.
Yeah, so this was a way of looking at the risk of RA-ILD over time, but while also accounting for relevant covariates. We found that the risk was most significantly increased among those with the highest quartile of multi-biomarker scores, where patients in this quartile had a nearly 20% risk of RA-ILD by 15 years. This is in comparison to the lowest 3 quartiles, which all had a risk within the about 5 to 10% range.
So you did do a lot of digging on this data set and you conducted a few additional exploratory analyses. What did those studies add and where is that taking you?
Sure. So we completed subgroup analyses stratifying RA-ILD by either UIP or non-UIP patterns. We saw significant associations of the multi-biomarker score with both UIP and non-UIP ILD, although interestingly, this seemed a bit stronger for non-UIP ILD. It's important to note that these analyses had relatively smaller sample sizes. There's also some risk for misclassification here due to the difficulty capturing ILD pattern in a chart review setting, so we're not entirely sure what the true significance of these results is. We also performed a sensitivity analysis where we looked at this multi-biomarker score but excluded MMP7. The reason for this is that we previously published in this cohort showing relatively strong associations of MMP7 with RA-ILD. While the removal of MMP7 attenuated the magnitude of the results, there were still positive associations observed, which suggests that there's a meaningful association of this multi-biomarker score with RA-ILD beyond that of just MMP7 alone.
Yeah. Did you do any other dives into specific biomarkers, analyzing them independently, or did that not reveal anything at all?
No, so we didn't do a deep dive into the individual biomarkers. There were a handful of biomarkers that just individually had higher levels or seemed to within some of the cohorts. But really, the only major adjustment that we looked at in this score was excluding the MMP7.
I feel we must mention this because you mentioned it at the beginning of the discussion. There were a few limitations of your study. Tell us about those, and then tell us about how this study is laying the groundwork for your future work.
Yeah, and so definitely some limitations to our work here. One of the limitations is that our validation cohort was a U.S. veteran population, and this may not be fully reflective of the general RA population. However, based on seeing similar findings of this score in our non-VA development cohort, we do anticipate that these findings may be generalizable to a broader RA population. Another limitation is that there's some risk for misclassification of RA-ILD, particularly in our validation cohort. So the registry participants are not systematically evaluated for ILD. In this case, we would expect this to most likely lead to an under-identification of RA-ILD, and we therefore would anticipate that this would most likely bias our observed results to the null. There was also a slight difference in how the score was defined in the cohorts, and so we didn't have availability of MMP2 levels in the VERA registry, so this was actually excluded from the score in the validation cohort. There were also subtle differences in how RA-ILD was defined between the development and the validation cohorts. But ultimately, we feel that the findings of this study further support the concept of shared common pathways between RA-ILD and IPF, and they would suggest a potential role for peripheral biomarkers in the prediction of RA-ILD.
Yeah, yeah. I mean, I feel like there's so many questions, right? When do you run the biomarker? When does it become important relative to the development of ILD? But this is just a nice kind of starting place to get the whole field looking at this more deeply. This panel is obviously not ready for the clinic. What's your sense of the future for biomarkers in RA-ILD? And you've obviously decided to dedicate a portion of your research time to this topic. Where are you going next with this work?
Sure. So, really, none of the individual biomarkers or composite panels that have been studied thus far in RA-ILD have an adequate performance to definitively help us decide which RA patients need screened for RA-ILD. I do think that biomarkers will have a future role in the screening for RA-ILD, although I don't think it's likely that a single biomarker in isolation is going to be enough to help us decide who does or doesn't need screened, how often they need screened, etc. Instead, I think the future really lies in the combination of biomarkers and/or biomarker signatures, combining these along with other clinical and epidemiologic risk factors to more accurately help us predict RA-ILD risk. And so if we can derive such a scoring system that performs with good performance, this could help us to target RA-ILD screening to the patients that are really the most likely to benefit.
Yeah, for sure. And I am going to watch your data as you work on this over the next few years. Let's take a little bit of a diversion now and hear about your journey into rheumatology and into science. You grew up in a small town called Gretna, Nebraska. Tell us a little bit about Gretna.
Sure. So Gretna is a small town. It's located a short drive outside of Omaha, Nebraska, where I'm located now. Gretna was a great place to grow up. It gave a nice taste of a small town life. And so I knew basically everybody in my graduating class. Going to the grocery store in town, there's always a familiar face around. But it was also close enough to a bigger city where you really didn't feel like you were missing out on any of those amenities or opportunities. The town really has grown quite a bit over the last couple of decades. So it's now basically expanded to the point where it's contacting Omaha and is basically a suburb of Omaha now.
Yeah, I heard that it's named after Gretna Green in the United Kingdom, which is actually where people go to elope. Is the same true for Gretna, Nebraska?
I don't know about that, and I can't tell you about the origin, but I can tell you that the school, at least the original high school that I went to, the colors are green and yellow. They have the logo looks like the Green Bay Packers.
Amazing. So growing up, did you know you always wanted to be a rheumatologist, or was there a pivotal moment that changed the course of your career and drew you into medicine and particularly into rheumatology?
Yeah, so I didn't really know that I wanted to be a physician until sometime early on in my college career, and I didn't know that rheumatology existed until sometime in medical school. I never really considered being a rheumatologist until I did a rheumatology elective during my fourth year of med school at the University of Nebraska. So during my time on that rotation, I got to work with several very talented people who really genuinely loved their jobs. And this really, to be honest, sold me on the field. I'm lucky now to be able to call many of these individuals my mentors and colleagues today.
Nebraska is quite the department, so you landed in a good place. You've been in your faculty position now for a few years. What skills and habits have been most essential for you in sustaining your long days, both as a physician and as a scientist?
So those long days can definitely wear on you when you're completing the same modules year after year in order to keep your job. Or after you explain away the significance of that positive ANA that probably shouldn't have been checked in the first place for the third time that day. Whether we're doing research or seeing patients in clinic, or if we're educating the next generation of health professionals, when times get hard, I think it's really helpful to look back at what originally led us to choose our paths in the first place. For me, and I think for many other rheumatologists as well, ultimately we're doing what we're doing in order to help the lives of our patients. I really think reframing these tough moments through that lens can be helpful and help you get through some of those tougher days. I think it's also important to take time away from work to recharge. And for me, I do that through quality time with family and through exercise.
Yeah, no, they're super important. And as an educator, how do you approach continuous learning and adapting to new knowledge in this constantly changing field?
So that can definitely be challenging. We have the great benefit of working in a field where things are advancing at a rapid pace, but that can also make it difficult to keep up to date on everything that we need to know. Working at an academic medical center is helpful for me personally as I get to interact with context experts, within their respective areas of rheumatology on a regular basis. It also helps out working with rheumatology fellows who are constantly pushing our knowledge to the limits, but also bring a fresh perspective and viewpoint on things. For me personally, I also find value in spending a few minutes reading on a topic when my patients come in with something that maybe I haven't encountered for a while.
Yeah, always should start with the patient. And I feel like they bring the best questions to us. Brent, I really want to thank you for sharing your important work and sharing your story with us today. I definitely am looking forward to watching your career grow and hearing more from you in the future.
Thank you so much.
As we close today's episode, I also want to offer a heartfelt thank you to all of our authors who keep pushing to get incremental findings into the world. Your persistence, draft after draft, revision after revision, moves science forward in ways that often go unseen but never go unfelt. Every careful analysis, every small advance, every data point that you fight to get published becomes part of the foundation that the rest of us stand on. And we're grateful for your dedication and determination to keep the story of discovery moving. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at ACR Rheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.